اولا انا حابب اشكر اسم الكلى، وحابب اشكركم جميعا. يعني I would like to thank my professor دكتوره هويدا الشناوي، واستاذي الدكتور هشام السيد، واختي طبعا العزيزه الدكتوره مها بحيري. مش عارف انتوا سامعيني ولا لا. انا بشكركم جدا جدا يعني على الدعوه الكريمه وعلى المؤتمر الرائع. You are significantly addressing one of the most important concerns in nephrology now, is how can we deal with critically ill patients, because actually more than 90% of the consultation we are consulted about are about how to deal with critically ill patients in ICU settings. And a large burden of those patients are having what I defined as the cardiorenal challenge. This was the title I've chosen to my lecture, to present how can we control the hypervolemia in those patients. And actually, I want to highlight if we can save the heart through the kidneys. Can be the kidneys and the medications working on the kidneys and the interaction between both control the cardiorenal morbidity, starting from the cardiovascular perspective primarily. We will see. But before we start, I want to highlight that there is some evolving subspecialization in nephrology in multiple aspects. One of them is cardionephrology. Cardionephrology means that there are some nephrologists who are specialized in managing different aspects of cardiorenal syndrome, utilizing the novel agents that has been introduced in the markets over the past 5 or 10 years to address both the cardiac and renal morbidity simultaneously at the same time, because we used to know that there are some contradiction of benefit between the heart and the kidney, and whenever you intensify the treatment on the heart, the kidney usually gets affected and vice versa. So this is the very well-known figure from the KDIGO guidelines regarding CKD classification, or the intercorrelation between varying classes of GFR and increasing proteinuria. And the color coding here is representative of the incidence of cardiovascular mortality. And as we go in this direction toward the red color coding, mortality risk increases significantly, which means that there is some sort of relationship between declining GFR, proteinuria, and more cardiovascular mortality. As we can see here on the figure on the left side, declining GFR is associated with increase in the hazard ratio of mortality, and an increase in proteinuria also is associated with increase in cardiovascular mortality. And in this trial, the effect of proteinuria and the declining GFR was leading to cardiovascular mortality independent of the presence of diabetes or not, as the color coding is showing. And we know formally that diabetic patients are going to be more prone to more cardiovascular mortality, but still kidneys and the kidney criteria has a rule. That's why chronic kidney disease patients have a 6-fold increase in cardiovascular risk of mortality rather than progression to end-stage kidney disease. So we should, while we are treating our chronic kidney disease patients conservatively, we should focus on the cardiovascular morbidity as well, rather than focusing when they are going to need renal replacement therapy, either dialysis or transplant. This is very, very important. So the pathophysiological mechanism here, as I defined as the cardiorenal crosstalk, if we can start from the heart, any myocardial injury will lead to low cardiac output, low perfusion state of the kidney, aggravated by activation of sympathetic system secondary to baroreceptors activation, which consequently will lead to RAS activation. RAS activation will lead to fibrosis, cardiac remodeling, intrarenal fibrosis, fluid retention, and aggravation of the cardiac morbidity from the very beginning. Again, another very important issue we see in cardiorenal patients is the significant volume maldistribution between the venous and the arterial circulation. Cardiorenal patients are significantly filled in terms of venous circulation, so the venous circulation transforms from low pressure, low volume to high pressure, high volume circulation with lung congestion. Meanwhile, arterial circulation is underfilled, so the perfusion of the organs becomes compromised. And one of the major organs that becomes affected is the kidneys, because it receives average to 20 to 25% of the cardiac output. That's why any manipulation in the distribution of volume between the venous and the arterial circulation, as we will see later, will affect the kidney in a negative way. The two main broad categories of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. I know there is a class in the middle which is mildly reduced ejection fraction, but we can talk about the majority. Both of them share in the incidence of venous congestion, both of them will need diuretics treatment with subsequent worsening renal failure, which is the terminology used by cardiologists to identify acute kidney injury on top of chronic kidney disease secondary to treatment intensification, which will be manifested to us by progressive increase in creatinine. But unfortunately, creatinine is not a true measure to highlight how the kidney is affected in a negative way, because it's coming from a multifactorial background related to muscle mass, nutritional state, and the extrarenal ways of loss of creatinine, which significantly becomes affected in heart failure patients. So we should depend solely on clinical assessment rather than minor fluctuation in serum creatinine. We should be confident enough to allow the creatinine to rise a little bit in a monitored way to be able to give the patient the maximum benefit. So how can we hit the core of cardiorenal syndrome? The classic is to use RAS inhibitor. RAS inhibitors has a very significant nephroprotective and the cardioprotective effect. And the main scope of our presentation, how can we offload such patients either with intensified diuretics treatment or with renal replacement therapy? And last but not least, the evolving era of SGLT2 inhibitors that started its life as anti-diabetic medications, and now their efficacy and their evidence has been extrapolated to involve non-diabetic cardiac, non-diabetic CKD patients. But the challenge that we usually face is when you block RAS while you are giving offloading therapy in a patient with chronic kidney disease, unfortunately, worsening renal failure is a must, and the kidneys start to suffer. So how can we adapt the heart failure management plan to chronic kidney disease? The 4 pillars for heart failure management, I'm talking here about heart failure with reduced ejection fraction, have been solidly defined in the guidelines, and it consists of RAS blockers, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. If we start to shed some light on RAS blockers, this is the very well-known RAS system starting from angiotensinogen in a cascade of events ending in aldosterone that leading to fluid retention and cardiac remodeling and intrarenal fibrosis has been the target for multi-point therapeutic modalities starting from ACE, ARBs, aldosterone blockers, classically spironolactone, and there is a new evolving era of the use of neprilysin inhibitor-based combination with valsartan, because this allows to preserve natriuretic peptides by inhibition of neprilysin enzyme responsible for its degradation. That's why this preservation will help to maintain natriuresis, help to vasodilate the blood vessels, and it has anti-proliferative properties. And when you combine this with classical angiotensin receptor blocker like valsartan, there is a significant augmented anti-failure mechanism happens. But is this medication friendly to the kidney? Yes, it's friendly to the kidney. That in the Paradigm HF trial, they studied a group of patients with HFrEF, and they compared sacubitril valsartan in comparison to the classic RAS blockade. They have chosen enalapril as a representative of ACE group, and as we can see in this trial, there was a relative GFR preservation in the arm who was treated with sacubitril valsartan versus enalapril. And when they did subgroup analysis of the people based on the incidence or the presence of diabetes or not, diabetic patients with reduced ejection fraction heart failure had a statistically significant preservation of GFR in comparison to patients who were receiving enalapril. So it seems that sacubitril valsartan is a friendly or renal friendly RAS blocker. The second, that's why in the guidelines here, they have changed from RAS to ARNIs. ARNIs now are prioritized over any type of RAS blockers in utilization in heart failure management, especially if the patient can afford it with proper financial cover. The second arm we are going to discuss is mineralocorticoid receptor antagonist, and formerly we used to use spironolactone, but currently we are living in the era of finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. Name is Kerendia, and they studied the cardiorenal endpoints in a large program. It's called the Fidelity program. They have chosen a varying grades of chronic kidney disease to involve patients with a GFR as low as 25 ml per minute, with proteinuria expanding from the microalbuminuria up to 5 grams per day, with a well-controlled background of diabetes and hypertension so as to not to act as confounders. And they were receiving the maximally tolerated ACE and ARBs as the classical RAS blockade. So this medication is added on top of RAS and ARBs. Regarding the cardiorenal endpoint analysis, the composite endpoint of time to cardiovascular mortality, non-fatal MI, non-fatal stroke, and hospitalization to heart failure was reduced by 16%. And individual endpoint analysis reviews that hospitalization to heart failure was the dominant rule why this composite endpoint was reduced, with a highly statistical difference between the groups favoring finerenone. Regarding the hard renal endpoint, time to renal failure, sustained GFR reduction more than 57%, which is equivalent to doubling of serum creatinine, and renal mortality was significantly reduced, and individual endpoint analysis was statistically significant. All comes in favor of the use of finerenone. Finerenone is superior to spironolactone because it's selective with less sexual side effects, less electrolyte disturbance, especially hyperkalemia, and it has anti-inflammatory properties secondary to aldosterone blockage. The last one is SGLT2 inhibitors. They have a very strong evidence from the guidelines to be utilized in HFrEF and HFpEF respectively, and we can say that this is the only evidence-based medicine that can be offered to diabetic patients with preserved ejection fraction heart failure. Regarding their effect on the kidney, it has been studied in renal-focused multiple trials studying CANA, DAPA, and IMPA glyphlosin respectively, in Credence, DAPA CKD, and IMPA kidney that was published earlier this year. And from the 3 trials, the hard renal endpoint of progression to end stage or doubling of creatinine or mortality coming from renal or cardiovascular perspective was reduced by an average of 28% up to 39%. And this is very significantly effective on the heart in an indirect way because of the hemodynamic hypothesis. Whenever you offload the patient from glucose, lipolysis will be stimulated and weight loss is the rule. And whenever you offload sodium, the patient gets less fluid retention, which will improve the cardiac preload and afterload and increase the myocardial oxygen supply, better cardiac output, better renal perfusion, and closed loop benefit. Cardiorenal happens. So we can focus here that the consensus guidelines published earlier from the KDIGO and ADA at the same time have prioritized SGLT2 inhibitors as members in the first-line drug therapy in CKD patients hand in hand with RAS. And regarding glycemic control, in line with for me, SGLT2 inhibitors are prioritized to achieve GFR as low as 20 ml per minute. GFR is deteriorating. They're now saying loud and clear, continue SGLT2 inhibitors outweigh any possible. So it seems that the kidney might be happy if you treat heart failure with sacubitril 10, finerenone, and SGLT2 inhibitors. So how can we float our patients? As a general rule in CARD patients, water is. These are the diuretics that we all know. We depend solely on them to prevent sodium absorption from here. By comparing them to thiazide, they are more potent, while thiazide shows some restriction to GFR if GFR falls below 30 ml per minute, except for metolazone, which can be faced by pre-renal azotemia. The heart failure guidelines still stating that loop diuretics is the favored agent of flooding, and they can be administered in a decongestion strategy in IV route in acute decompensated heart failure patients. But the hemodynamic that happen in those patients, and the here on the left side representing circulation, and on the right representing the arterial circulation supplying. Normally, you have a state of normality of volume for both of them. And when you intensify diuretics, in heart failure patients, the venous circulation becomes high pressure, high volume, as we mentioned, and arterial circulation becomes underfilled, and the blood pressure is low because of low cardiac output. And when you intensify diuretics, unfortunately, the volume is controlled, symptomatic relief happens, but the arterial circulation becomes more underfilled and the kidney gets affected. Another issue that faces us while we are using loop diuretics is loop diuretics resistance.
And it can happen due to a variety of causes. I know Dr. Fatma have shed some light about these issues, but I want to highlight the flow-mediated hypertrophy in the distal convoluted tubule, the aldosterone-mediated sodium reabsorption in distal convoluted tubule and in the collecting duct, and lastly, the glomerulotubular balance reabsorbing most of the sodium in the proximal tubule, secondary to low renal blood flow. So how can we overcome this? We overcome this by the use of sequential block, which means combining diuretics together. We start with metolazone, which is the favored agent here. It can work in low GFR state, blocking sodium reabsorption, distal convoluted tubule, and in the proximal convoluted tubule as well. Spironolactone and recently finerenone, it blocks aldosterone-mediated sodium reabsorption distally. And SGLT2 inhibitors here might play a role to block sodium reabsorption in the proximal convoluted tubule. And there are some data regarding acetazolamide in an IV form that might help to potentiate the action of Lasix. So from the guidelines, addition of a second diuretic, preferably metolazone, is highly suggested. So back to our patients with compromised circulation after intensive diuresis, how can we support this patient? Can we offer him osmotic support with albumin or hypertonic saline? Can we modulate RAS blockers while we are on intensified diuretics? Osmotic support, we suggest that saline salt-free albumin solution should be offered to some patients, especially patients with albumin level less than 2 grams per deciliter to support the plasma oncotic pressure. And because furosemide or loop diuretics itself are protein bound, that this facilitates diuretic delivery to the renal tubules. But unfortunately, there was no studied randomized control trials in that field. While hypertonic saline, there is a hypothesis that says that supporting the circulation of the hypertonic saline while we are intensifying diuretics might be of very significant benefit. And this was studied in this paper published in the Journal of American College of Cardiology Heart Failure in 2020. And in this trial, they have been administering hypertonic saline to a group of patients, 40 patients exactly, who were treated with diuretics alone. And it was found that the electrolyte derangement, creatinine fluctuation was significantly improved, urine output and weight loss significantly improved, diuretic efficiency significantly improved, with no added harm to serum sodium level or respiratory state. So the proposed infusion plan in this trial was 150 ml hypertonic saline with a osmolarity range ranging from 1.4 to 4.6%, and it's given by infusion twice daily. What about RAS modulation? In this trial, they have studied whether to stop or to continue RAS blockade while we are intensifying diuretics in patients with acute heart failure. Was published in International Journal of General Medicine 2021, and there was no statistically significant difference noted regarding kidney function or diuresis, but it was found that the length of stay for the patient who held their ACE and ARBs was significantly shorter. Another expert opinion coming from UpToDate that it's better to stop or withdraw RAS blockers while you are intensifying diuretics, and I think from our clinical practice, we support this idea because it allows for better kidney autoregulation to variation in the circulation. So how can we administer loop diuretics, bolus versus infusion? Actually, this issue has been studied in multiple trials. These are 6 trials, although they are less numbered, less powerful, but at least 4 of them showed that infusion is better in terms of reducing ototoxicity and better dose response. Meanwhile, 1 trial showed that bolus is better, and a 3rd trial showed that there was no difference. But the dose trial has been mentioned by name in the American Heart Association guidelines when they compared bolus versus infusion and low dose versus high dose strategies regarding VAS score, which is a score used for assessment of volume overload symptoms, and there was no statistically significant difference regarding the use of bolus versus bolus versus infusion and low versus high dose, but creatinine was relatively higher while on continuous infusion or high dose diuretics, but it didn't reach any statistical significance. In the same trial, they have been chasing a survival endpoint of mortality, rehospitalization, or emergency department visits during the 60 days follow-up period, and there was no statistically significant difference between infusion and bolus and low dose versus high dose. Loop diuretics, as we all know it, furosemide, bumetanide, torsemide. The most commonly used is furosemide. In heart failure, you can start by 20 milligrams twice daily, increase it to up to 80 milligrams three times daily with a ceiling of 600 milligrams, after which the benefit from the diuretic might not outweigh the risk of ototoxicity. We know that chronic kidney disease patients, we need to start with a higher dose that can reach up to 200 milligrams three times daily, which represents the same ceiling of the dose. So can we utilize renal replacement therapy in such patients? Yes, we can, but we have to consider the timing, whether the patient is coming in an elective situation just for offloading. You should start pharmacological treatment first, or just emergency pulmonary edema, not responding to diuretics in a short time frame with a severely impaired kidney function. And how about the frequency, whether we will use intermittent dialysis or continuous renal replacement therapy? This is also a question to be considered. And what is the modality? Is it hemodialysis, SLED, ISO-UF, HDF, SCUF, or even PD? Some points to be considered when doing the decision or taking the decision regarding these points are the clinical situation of the patient and the response to pharmacological treatment, in addition to hemodynamic stability, because we all know that continuous therapies are more hemodynamically gentle, and it allows the patient to be compensated without severe compromise and need for more inotropic therapies, and also the availability of the modality. Not all healthcare facilities have CRRT. Not all healthcare facilities can continue on maintaining CRRT due to, of cost-related reasons. There are some trials that compare diuretics efficacy versus ultrafiltration in heart failure. There are 4 trials I'm showing here, starting from Unload trial in 2007, to Avoid HF trial in 2016, and to conclude, ultrafiltration offered rapid symptomatic relief, more weight control, less incidence of rehospitalization during 3 months up to 1 year, and there was no effect on mortality outcome. So it's just the morbidity of hospitalization, the morbidity of heart failure decompensation gets benefit from early initiation of ultrafiltration rather than depending solely on diuretics. There are some general rules when we are prescribing renal replacement therapy. The first one is the mortality rate is not affected by whichever you're going to choose regarding continuous versus intermittent therapies, but we all know that continuous therapies, as we mentioned, are more gentle on patients with hemodynamic instability. Pure ultrafiltration, or like what cardiologists say, aquapheresis, they have a standalone machines just for ultrafiltration, might lead to less blood pressure fluctuation in cardiorenal patients because it allows to retain uremic toxins in the patient, which has an osmotic power to maintain the blood pressure stability. If you are going to choose SLED, it's suggested to continue from 6 to 12 hours with a blood flow rate might reach 150 ml per minute and dialysate flow rate that might reach 300 ml per minute. If you are going to choose continuous therapies, either hemodialysis or diafiltration, the average duration is 24 hours with a blood flow rate up to 150. Dialysate flow rate might reach up to 6,000 ml per hour and targeting effluent rate of 20 to 35 ml per kg per hour. And if you can afford regional anticoagulation or extracorporeal anticoagulation with citrate calcium infusion, this will reduce the gap between the prescribed and the delivered dose because it allows for maintenance of the membrane function and it allows for less frequent kit change. So our take-home message is today that the cardiorenal specialty should have more focus because it's an evolving specialty in renal medicine, introducing new tools of management of cardiorenal patients together, getting benefits together. Diuretics remains the gold standard for offloading, especially loop diuretics, which can be supported by thiazide diuretics, especially metolazone, with a dose range ranging from 2.5 up to 10 milligrams per day to prevent refractoriness. And the use of renal replacement therapy for volume offloading offer a significant volume control in a shorter time frame, yet it didn't affect cardiovascular mortality. Sacubitril valsartan is superior to conventional ACE and ARBs in HFrEF patients, especially in diabetic population. It helps to preserve GFR more. Finerenone is superior to spironolactone as anti-failure measure with a very strong evidence regarding renal morbidity or renal hard endpoints reduction, especially in diabetic population. And the SGLT2 inhibitors, they have a solid nephroprotective effect that it can be used now in non-diabetic CKD population and to a GFR as low as 20 ml per minute, and can be used in combination with loop diuretics to prevent its refractoriness by blocking proximal tubular sodium reabsorption. Thank you so much. It was an honor to me to be with you here, and I'm ready to, if you want to ask any questions. Thank you so much.
دكتور محمد سامعني؟
ايوه يا دكتور وليد مع حضرتك.
الحقيقه very nice presentation, excellent presentation الحقيقه as expected يا دكتور محمد. And I have two questions بس ليك على البرزنتيشن. في البرزنتيشن اول حاجه هل كان في اي ستاديز او انت شفتها سواء من ريال لايف ستاديز او ستاديز موجوده عن الاكواريتكس، الرول اوف اكواريتكس في الفوليوم اوفرلود في الكارديورينال، هل والايكويفالنس بتاعها مع اللوب دايوريتكس اند اذر دايوريتكس؟ ده السؤال الاولاني. السؤال الثاني على الحته برضو عجبتني جدا دي اللي بنشوفها كل يوم، هو البولس فيرسس الانفيوجن في اللوب دايوريتكس في العيانين دول. هل كان في ديفرنس في الستاديز على بيزد على الهيموداينامكس اوف ذا بيشنت؟ يعني هل العيان اللي بيبقى ضغطه قليل بفضل له مثلا الانفيوجن عن البولس او العكس؟ هل في حاجه عن كده ولا لا؟ لان دي دايليما احنا بنقع فيها دايما في العيانين اللي في الاي سي يو او اللي بنشوفهم دايما يعني.
شكرا جزيلا يا دكتور وليد، وانا متشكر جدا لاسئله حضرتك. يعني first of all I didn't involve the use of aquaretics, tolvaptan and vasopressin blockers in my presentation, because actually I thought that it's going to be included in other presentations of my colleague, but at use is a standalone utility regardless the use of loop diuretics. So I tried to shed some light on the way we can potentiate the action of loop diuretics, because according to the international guidelines, they are still the gold standard tools that can be used for offloading our cardiorenal patients. But still there are some evolving data regarding the use of vasopressin, but not as a supporter to Lasix. It's a standalone therapy, but it's still not listed strictly in the guidelines. And you know, Dr. Walid, that these medications are very expensive to be utilized in our daily practices. There are still some trials talking about the value of these medications in polycystic kidney disease patients, and to the moment, the rule was not generalized because of cost restriction and cost benefit. So regarding your question, if they are going to be added on top of loop diuretics, yes, but not as potentiator to loop diuretics. The second question about bolus versus infusion, actually they have chosen a homogeneous group of patients regarding hemodynamics and regarding the acuity of heart failure. So one of the trials have included chronic heart failure stable patients coming just for offloading, and other trials they included patients with acute heart failure. And I tried to collect the pool of data, the major points, so as not to lengthen the duration of my presentation. And as a summary, infusion, and from my own clinical practice as well, infusion, it seems better in terms of cumulative dose response. So if you assume that you are going to give the patient 80 milligram of furosemide, if you divided this all over the day, the dose response is going to be much better, and you will not be in need to escalate the dose to a higher level that might carry an ototoxic or nephrotoxic by interstitial nephritis effect.
تمام. محمد، ازيك الاول؟ دكتور محمد، اخبارك ايه يا حبيبي؟
اهلا.
بص انا الحقيقه بتكلم، انا بس ايه، ما عنديش سؤال قوي، بس بتكلم اسلم عليك، يعني فاهم ازاي؟ توحشنا جامد، والمحاضره الحقيقه يعني فوق الممتازه، ويعني وفعلا يعني از اكسبكتد. يعني دكتور محمد يا جماعه كان برضو كان يعني طبعا نسيت اقول لك صحيح، مبروك يعني حاج مبرور.
الله يبارك فيك، ربنا يكرمك.
ادعي لنا بقى كلنا. ها
ان شاء الله، دعيت لكم ربنا يتقبل مننا جميعا.
الله يخليك يا محمد،
الله يكرمك
يا حبيبي،
ربنا يبارك فيك.
ماشي يا فندم. في شهاده تكريم تقريبا دكتوره معاها حطها، مش عارف وصلت لك على السكرين ولا لا؟
وصلت لي، شايفها.
طيب تمام.
جدا جدا ليكوا متشكر جدا. الانتمائي ليكوا لا عمره مش هيتغير، وان شاء الله لينا عوده نبقى وسطكم نتعلم منكم جميعا، ودايما في بيننا الود والمحبه وبنعلم بعض وبنزود بعض ان شاء الله. ومتشكر جدا لاختي الدكتوره مها اللي دايما واقفه جنبنا وبتساعدنا، ودايما بنشوفها على خير وبنشارك معاها ان شاء الله.
شكرا دكتور محمد على مشاركتك الدايمه معانا.
دكتوره هويدا اهلا بحضرتك يا فندم.
مشاركتك الدايمه معانا، ودايما كده يا رب كل سنه يعني بتشرفنا بالمحاضرات القيمه اللي بتقولها لنا. نشكرك جدا جدا، والف مبروك على الحج، وعقبال عقبالنا كلنا يا رب.
اللهم امين. متشكر جدا جدا دكتوره هويدا، وانا بشكر جدا حضرتك لاهتمامك بان انا اشارك معاكم، وانا دايما دي حاجه بتسعدني، يعني مهما شاركت في اي اكتيفيتيز، المشاركه وسط اهلي ووسط البيت اللي انا اتعلمت فيه دايما هي اهم حاجه عندي. شكرا جزيلا.
شكرا دكتور محمد. انا برضو بتكلم علشان اسلم عليك. وحشنا.
والله حضراتكم كلكم وحشني، ويعني دايما
ان شاء الله نشوفك
يعني
عن قريب.
وانا شغال بسمع كلام حضراتكم وانتم بتعلمونا في كل عيان انا بشوفه. متشكر جدا.
شكرا جزيلا.